talked about early on in yesterday's talk, but I will just highlight certain important points when talking about the anatomy of the orbit. For surgical purposes, it helps to think about the orbit in terms of the orbital frame as well as its orbital walls. The rim itself consists of the frontal, zygomatic, and maxillary bones, and often can be thought of and described as a spiral with two ends overlapping medially on either side of the lacrimal sac fossa. The walls themselves are much thinner, with the lamina papyracea being the thinnest bone of the orbital walls. However, despite the LP of the medial wall being the thinnest orbital wall, the floor of the orbit is the most frequently fractured and most severely disrupted part of the orbit. Even though the LP is the thinnest, it is reinforced by the honeycomb structure of the ethmoidal air cells just adjacent to it. However, the posterior part of the orbital wall is the weakest, as the part medial to the infraorbital groove is significantly thinner than the bone lateral to it. It is thought that when there is force applied to the globe, as in the hydraulic mechanism theory, this pressure either causes the orbital bones to break or blow out at the weakest point. Either that or the buckling mechanism theory that we are also familiar with, where forces are transmitted through the deformation of the orbital rim. Having briefly just looked at the anatomy, we turn our attention to some of the different classification systems that have been described for orbital wall fractures. Perhaps the most well-known facial fracture classification of all has to be the Lefort classification, described way back in 1901 by René Lefort. And by definition, Lefort fractures extend posteriorly through the pterygoid plates and can be categorized and divided into three categories. Lefort 1 fractures are low transverse maxillary fractures through the teeth with no orbital involvement, so oftentimes are not that relevant to the oculoplastic surgeon. Lefort 2 and 3 though involve the orbital walls, so the Lefort 2 fractures generally have a pyramidal configuration and involve the nasal, lacrimal, and maxillary bones, as well as the medial orbital floor that you can see in the diagrammatic representation below. Lefort 3 fractures, they cause craniofacial disjunction, in which the entire facial skeleton is completely detached from the base of the skull and is suspended only by soft tissue. The orbital floor, as well as the medial and lateral orbital walls, are involved in the Lefort 3 fractures. There are, however, limitations to this classification which precludes its universal use, mainly because it does not describe all orbital and facial fractures, that fractures do not conform precisely to these three groupings and can present as a mixture of the three types, and also that fractures are often asymmetric, they don't come symmetrically to us, unlike what is depicted in the Lefort classification. But perhaps the most detailed and comprehensive one is the AOCMF classification. This is a classification which divides cranio-maxillofacial fractures into a hierarchy with three levels of precision in order to describe these injuries with accuracy and detail. Very quickly, level 1 is the most basic. It conveys only whether fractures are present in 4 anatomical units: the mandible, the midface, the skull base, as well as the cranial vault. Level 2 describes the location of the fractures in detail within specific regions as defined in level 1. And level 3 defines and reports even greater detail about the location of the injury, but with a focus on the morphology of the fracture itself, including the fragmentation, the displacement, as well as the bone defects within these previously described specific subregions. For classification of orbital fractures in this system, the orbital walls are assessed independently from the bones that they originate from. So this is what the authors term as a geometric concept of classification. In this concept, the anterior part of the orbital cavity is referred to as the anterior third, and the so-called mid-orbit refers to the middle third of the orbital cavity. From the anterior third to the middle third of the orbit, the four walls make up a quadrangle in the coronal cross-section. In the 3D view that you can appreciate here, this configuration is pyramidal in shape, with the base located over the anterior orbital entrance. When we reach the posterior third of the orbital wall then blends into the medial wall, resulting in a triangular-shaped coronal cross-section of the apex region. Now, simply put, this just means that the orbit is a four-sided pyramid that becomes three-sided as you advance towards the apex. In the AOCMF classification, there's also special attention directed to identification of three important intraorbital structures, mainly the inferior orbital fissure, the intraorbital buttress, which is a bony condensation at the confluence of the medial orbital wall and the floor. And lastly, the posterior ledge, a solid shelf in the posterior orbit, and is essentially part of the palatine bone. The IOF is relevant for a couple of reasons. The first is that it serves as a landmark that divides orbit into parts of three. Now, secondly, this zone is also crucial for assessment of orbital injuries, as fractures of the floor extending posteriorly may result in enlargement of the fissure and therefore also the orbital volume. Next is the intraorbital buttress. It is the bony condensation along the ethmoid maxillary suture line, which is the confluence of the medial orbital wall as well as the floor of the orbit. The intraorbital buttress often remains intact in orbital trauma, so its involvement is often a surrogate for the severity of the trauma. And when uninvolved, it also serves as an important landmark for reconstruction. Lastly, we come to the posterior ledge, which is a solid shelf in the posterior orbit medial to the IOF. We all know that the orbital floor takes on an S-shaped profile with an elevation or bulge as we proceed towards apex. The posterior ledge hence serves as a reliable and stable landmark for accurate volumetric assessment and reconstruction of the posterior orbit. As you can imagine, without taking into account the unique contours of the orbit, proper orbital volume and shape is hard to be achieved. Which now brings us to the actual classification and coding of this system. In the AOCMF classification, fractures of the midface, the skull, the base, and the cranial vault are identified with 2-digit codes. In coding the orbital fractures according to their topography, in the level 3 system, the orbital structures are identified by letters, where R stands for rim, W for wall, A for apex. And the level 3 coding provides a specific orbital fracture identification to be specified separately from the overall level 2 coding. And it's very complex. So what does all of this mean? Honestly, if you had trouble following the classification, so did I. And it is one of the major reasons why this classification system, even though it's comprehensive, never really fell into widespread use amongst orbital surgeons. So, what should we then use, right? I mean, just because the classification is comprehensive and all-encompassing, it doesn't necessarily mean that it's practical. So what is ideal? Now, an ideal classification should be universal. It should be comprehensive, but yet minimalistic. And it should be easy to implement. And it should be something that is able to facilitate communication between different specialties, and should not be something that is static and unchanging, and hence is amenable to change. And lastly, it should be visually based and intuitive. And I don't think I can be a fellow of Dr. Danga if I don't talk about his classification system in his book, Orbital Fractures. And he proposes a classification system that first splits the orbit fracture into simple versus complex. Now, this is very intuitive. You think about simple fractures as being those that involve only the orbital walls, including linear fractures, blowout fractures, or less commonly blow-in fractures. On the other side of the spectrum lies the complex fractures, which are fractures that involve other parts of the facial skeleton, and these include your ZMC fractures, your NOE fractures, your orbital-facial fractures, cranial-orbital fractures, or pan-facial fractures, if it also involves the mandible. Like any good Singaporean, we all love our acronyms, and the second part of this classification is what makes it so powerful, because it's easy to remember. If you know your ABCs, you will remember this classification system. A stands for age, so is it a pediatric, adult, or geriatric subgroup that we're talking about? B refers to whether or not it's bilateral or unilateral, so it's the laterality of the fractures. Complexity refers to whether or not it's simple or complex, as described in the previous slide. D stands for displacement, E for entrapment, F for foreign body, and G for whether or not there's globe involvement. So, for example, when we're summarizing a case, when we see one, we may say this is a case of a geriatric bilateral complex ZMC fracture with moderate displacement, no entrapment, no evidence of foreign body, and no associated globe injury. So just with this sentence alone as a summary, it encompasses a lot of things, not just the patient, what type of fracture it is, but also the patient profile. And since its original description, the acronym has taken a life of its own, has further expanded to include H and I. Now, H represents whether or not the patient is high risk for intervention and general anesthesia, and I to stand for intervention, making it even more complete. It takes us full circle from describing the fractures, the patient profile, to whether or not the patient should receive surgical intervention. This is something that we now use routinely in our practice when seeing our orbital and facial trauma patients, and we found that the documentation helps not just with the internal communication amongst our plastic surgeons and the team, but also with our colleagues in other subspecialties. So really the key take-home messages that I want to drive today is that first, classification systems are